Welcome to Mitigating Cardiovascular Healthcare Disparities, New Guidelines for Cholesterol Treatment, a joint presentation of the National Heart, Lung, and Blood Institute and the Home Health Quality Improvement National Campaign. We're so pleased that you've joined us for today's presentation. During the next hour, you'll learn to identify and overcome obstacles to effective, equal treatment of atherosclerotic cardiovascular risk and disease. Understand and apply new American College of Cardiology and American Heart Association cholesterol treatment guidelines, enable patients and providers to discuss treatment goals, and improve provider adherence to treatment guidelines and improve patient adherence to medical regimen, and thus reduce and or eliminate cardiovascular healthcare disparities. There will be multiple opportunities for questions and answers a little later in the presentation today. We ask that you send your questions and comments to hhqi@wvmi.org at any time, and we'll get to as many as time will allow for today. At this time, I'm pleased to introduce our keynote speaker, Dr. Patrice Devine-Nickens, MD, who is a medical officer in the Heart Failure and Arrhythmias branch at the National Heart, Lung, and Blood Institute, part of the National Institutes of Health. Dr. Nickens is an experienced clinical trialist and is the project officer for the atherothrombosis intervention in metabolic syndrome with low HDL, high triglycerides impact on global health, also known as AIM-HIGH. Dr. Nickens has managed trials in acute coronary syndromes, heart failure, diabetes, and revascularization, cardiac surgery, and use of left ventricular assist devices in advanced heart failure. She is particularly interested in disparities in the practice of medicine and cardiovascular health. And now it is my great pleasure to turn over today's presentation to our keynote expert, Dr. Patrice Devine-Nickens.
Well, thank you. I'd like to thank the organizers for the opportunity to discuss atherosclerotic disease prevention and treatment and mitigating healthcare disparities. So if I could move to the next slide. Cardiovascular diseases represents the largest health burden to the American public, despite substantial reductions in death rates since 1960. Research elucidating disease-causing risks and conditions and subsequent treatments has and continues to offer opportunity to reduce cardiovascular morbidity and mortality. Atherosclerotic cardiovascular disease, specifically heart attacks, strokes, and peripheral artery disease, is the major component of cardiovascular disease. Its prevention or reduction of risks is a key strategy for reducing morbidity and mortality, related healthcare costs, and protecting the longevity and quality of life of Americans. The next slide, please. In this presentation, I will reinforce the importance of cardiovascular health burden. Women and racial and ethnic minorities have poorer cardiovascular disease outcomes relative to men and to whites. While there are differences in disease presentation, patient preferences, and many issues, disparities in health care are an important contributor to poor outcomes in these underserved populations. The new ACC-AHA guidelines for cholesterol therapy address risk and the potential to reduce risk with statin therapy. This new strategy may reduce treatment gaps among populations. If I could go to the next slide. The specific objectives for the attendees today are to identify and overcome obstacles to effective equal treatment of atherosclerotic cardiovascular disease, understand and apply new 2013 American College of Cardiology and American Heart Association cholesterol treatment guidelines, enable patients and providers to discuss treatment goals, and finally improve provider adherence to treatment guidelines and improve patient adherence to medical regimens. And this will reduce or hopefully eliminate cardiovascular health disparities. If I could go to the next slide. So this graph demonstrates the rapid rise of deaths due to cardiovascular disease in the 20th century. You'll note a sharp decline, 3% per annum since 1960. Next slide. Modern cardiovascular medicine has improved survival. If you could advance one again. The average life expectancy is age 78, with women enjoying superior survival at 81 compared to men. If you could advance, blacks, however, have shortened life expectancy compared to whites. Okay. This graph displays death rates by age and by race. Among African Americans, whites, American Indian Hispanics, and Asians, heart disease death rates by age and race show that blacks in the green bar have the highest death rates throughout the lifespan. Next slide. This graph demonstrates that the number of heart deaths in women exceeds the number of heart deaths in men, and this has occurred since 1983. And I might also point out that in the 80s, early in the 80s, late 70s, there's a disturbing trend where where you can see that there's a decrease in the death rates for men, while there's an increasing death rate in women just before this crossover. Next slide. Hypertension is an important risk factor for cardiovascular disease. From this early interval between 1976 and 1980, you can see that blacks, the darkest in the middle, black men and female, blacks have the highest prevalence of hypertension and also demonstrate a lower rate of improvement compared to whites and Mexican Americans over the 4 intervals displayed here. The next slide. So gender differences in burden of cardiovascular disease demonstrate there is a similar or greater burden of cardiovascular disease in women compared to men. If you could advance, there's an animation. Thank you. Just to underscore that the burden to women is similar or greater, and it doesn't matter whether it's cardiovascular disease, specifically coronary heart disease, stroke, or even heart failure. Next slide, please. Additionally, risk factor burden is also similar, although in this case for obesity, you can see that men have a slight increase compared to women. However, black and Hispanic women are exceptions, both of which the women are more obese than their men. Again, the high risk of burden underscores the importance of equal aggressive therapy for both men and women. If I could have the next slide. So in this graph, one can see that it's not until age 70, in the last bar, that the prevalence of heart disease in women actually exceeds the prevalence in men. Next slide. So in 2001 and again in 2010, the Institute of Medicine specifically considered sex and gender differences. In a separate report in 2002, the Institute of Medicine also examined unequal treatment. So sex and gender differences in presentation, signs and symptoms, and even diagnostic evaluation may complicate recognition. But a key message here is that unequal treatment, and in this case, quality of care, and you can see the difference between, on the y-axis, you see increasing quality, and you see this difference between the white bar and the blue bar, indicating a disparity in quality of care. And that's an important contribution to cardiovascular outcomes. And this is what we mean when we talk about health disparities or healthcare disparities. And disparities of this nature must be remedied. We could go to the next slide. Let's look at a few examples of disparities. So providers with high numbers of prescriptions for coronary artery disease medications were invited to participate in a quality assurance program. Medical records were reviewed from random sample of patients with coronary artery disease over a 3-year period between 1995 to 1998. The data related to the detection, treatment, and control of dyslipidemia were abstracted from medical record and evaluated in cross-sectional stratified and logistical regression analyses using generalized estimation equations. Comparing findings in 1,000 blacks to 22,000 whites, if we could go to the next slide, African Americans were younger, more likely to be women, and to have diabetes, heart failure, and hypertension. The LDL cholesterol testing rate for white men was over 1.4 times higher than that for African American women and about 1.3 times higher than for African American men. Almost 60% of tested white men and less than half of tested African Americans were prescribed lipid-lowering drugs. So the tested and treated white men had the highest LDL cholesterol attainment, while African American had the lowest. The authors conclude increased lipid testing is needed for African Americans. Improvement in treatment and control are also necessary to eliminate disparities in lipid management. But the disparities in treatment and goal attainment are not well understood, and given the high risk burden in African Americans, policies to improve health of underserved population is a compelling need. We can go to the next slide. So this is another example of a disparity. This is lipid therapy among veterans in a cross-section of persons who had both diabetes and hyperlipidemia. Women age match and facility match were compared with men. The proportions of patients with any prescription for lipid-lowering therapy in this study was compared to those with elevated LDL-C greater than 100 milligrams per deciliter and no prior treatment or end initiation of lipid-lowering therapy. The findings were that women had higher LDLs than men, but were less likely to be receiving lipid-lowering therapy or to be initiated on therapy. The differences were greatest in the youngest women age group, less than 45 years, for both any lipid-lowering and initiation of therapy, and the findings persisted after adjusted for potential confounders. So the conclusion in this study was that women veterans with diabetes and hyperlipidemia received less aggressive lipid-lowering therapy than men, and this, of course, is disappointing since early intervention to control hyperlipidemia can reduce the later burden of cardiovascular disease among diabetic women. So if I could go to the next slide. On a more positive note, this is a study from the Get the Guidelines Quality Improvement Program, which are promising. This is a program to address reported disparities in application of evidence-based treatment guidelines for women and elderly evaluated in over 237,000 patients hospitalized with coronary artery disease from 2002 to 2007. 6 measures, including aspirin on admission and discharge, beta blocker use at discharge, angiotensin converting enzyme inhibitor or angiotensin receptor agonist use, lipid lowering medication use, and tobacco cessation counseling, along with other care metrics, were monitored. Over time, the composite adherence on the 6 measures I mentioned earlier increased from 86.5% to 94.4%, all excellent numbers, but that improvement was in the younger age group And it also increased from 83% to 91% in the elderly. So both younger and elderly groups are often undertreated. So this is, a good example of quality improvement programs that work. So I could go to the next slide. So eliminating treatment disparities is an excellent segue to the new 2013 cholesterol treatment guidelines. The focus on atherosclerotic cardiovascular risk reduction is to treat at-risk patients that will benefit. The strategy of risk reduction may be helpful to women and minorities and other undertreated subgroups. Previous cholesterol targets, not by design, but whether screening for initiation or target goal, tended to exclude groups. The simple algorithm and emphasis on healthy lifestyle is easy for satisfactory patient and provider dialogue and cooperation. The next slide, please. The previous ATP3 cholesterol guideline was last released in 2001 and again updated in 2004. Its approach is comprehensive, but it's very complex. In 2008, the National Heart and Lung and Blood Institute initiated new guidelines by sponsoring rigorous, systematic evidence reviews. In 2011, responsive to the Institute of Medicine report calling for the highest quality evidence, NHLBI partnered with other organizations as a part of this process. Evidence after 2011 has not been considered in these guidelines, but we can expect updates as soon as this year even. If I could go to the next slide. The new guidelines is limited in scope in part because only the highest quality evidence was required. So if there's not high quality evidence, there is no recommendation. The text to support recommendation is succinct and clear. The format is changed. Recommendations are mapped from the NHLBI grading format to the ACC AHA class of recommendations and level of evidence. The alignment between the systems are imperfect, but nevertheless, the guidelines were released after independent expert review, scientific review and approval by partners, and review and endorsement by professional groups. There's also conflict of interest, specifically dealing with the relationship with industry, which is disclosed. But in short, this was an arduous, lengthy, and costly process. But the guidelines are straightforward and well supported, and we can expect frequent updates. However, it is a dramatic departure from previous approach. If I could have the next slide. I just want to mention that while the guidelines focus on trials for clinical management, there's decades of research in genetics, biochemistry, the underlying why cholesterol contributes to atherosclerotic cardiovascular events, animal models and preclinical studies that have also been conducted to develop evidence are recognized and establish direct relationship and causal pathway for why elevated LDL cholesterol is associated with atherosclerotic cardiovascular events. The next slide. This is the graph, which really was developed during ATP3, that demonstrates this direct relationship between elevated cholesterol and CHD risk and really drives the desire to reduce this risk, reduce events. The next slide. Now, this slide is just to review the various therapies that lower LDL cholesterol. We will spend the remainder of this talk discussing statins, that is the HMG-CoA reductase inhibitors. But I also just want to mention that non-statin drugs have been tested: bile acid sequestrants, cholesterol absorption inhibitors, nicotinic acid, and dietary adjuncts. These were reviewed, but while there are over 28 trials demonstrating the effectiveness of statins, the evidence for other non-statin therapy is poor, and they are not recommended. The next slide, please. So this slide is just to show that statins inhibit the Mg-CoAce reductase enzyme. If you would advance to the next slide. Yeah, so there is where the reductase enzyme is blocked, and that leads to a reduction in hepatic intracellular cholesterol. If you advance again. So in the next slide, if we could advance once more, statins decrease hepatic cholesterol synthesis, leading to the upregulation of LDL receptor on the surface of the hepatocytes. This increase in hepatocyte LDL receptor results in increased clearing of LDL cholesterol particles from the serum and ultimately lowers serum LDL cholesterol levels. If I could go to the next slide. Thank you. This table is just a reminder that if you double a statin dose, you can expect an additional 6% reduction in the LDL cholesterol. We could go to the next slide. The new guidelines require consideration of atherosclerotic cardiovascular risk and its reduction. The old targets that we've spent the last 15 years trying to remember, LDL and non-HDL-C targets, are abandoned. Rather, global risk assessment for primary prevention is an important consideration. There are safety recommendations, and the role of biomarkers and non-invasive tests are also included in estimations of risk. And we can expect future updates. If we could go to the next slide. So for the recommendations, a key or pivotal recommendation is that lifestyle modification is the foundation for atherosclerotic risk reduction. Specifically, heart-healthy diet is a must. Strong evidence that reduction of salt and following either a Mediterranean or DASH diet, both of which focus on limiting meat, red meat, and using legumes, fruit, and vegetables, have strong evidence that show their value in reducing atherosclerotic cardiovascular risk. Also, regular exercise, aerobic and strength building exercise for 30 minutes as often as you can, but certainly 4 times a week, is very beneficial. Avoid tobacco products and maintain a healthy weight. And again, want to underscore that atherosclerotic cardiovascular risk reduction must include both an understanding and commitment to healthy lifestyle. Our patients shouldn't be on drugs without at least having this conversation and trying to get them to understand the importance of a healthy lifestyle. Next slide. So non-statin cholesterol-lowering drugs have fewer trials and lack evidence for significant additional atherosclerotic cardiovascular disease event reduction and are not recommended. LDL cholesterol and non-HDL treatment targets, widely used over the past 15 years, are problematic and are not recommended. This is because clinical trials evidence really don't use specific targets. No evidence for atherosclerotic cardiovascular reduction by differential has really been demonstrated. So again, the LDL, in addition of drugs, may give you some additional change in the serum cholesterol measures, but whether that differential is what's making a difference in events is something that has not been demonstrated in clinical trials. And finally, the combination of these drugs does not consider the adverse effects that can occur from multi-drug regimens. If I could go to the next slide. The idea that the LDL cholesterol lowest is best is an approach that is abandoned because of the potential adverse events from multi-drug regimens. instead treat the level of atherosclerotic risk. A modified version of this approach is adopted. That is, there are new calculators for a 10-year atherosclerotic cardiovascular risk score. And that score is very helpful in identifying risk, especially for patients that heretofore have been have not had good estimates, specifically women, some women, particularly minority women and minority men. Lifetime risk approach was considered but was not taken because of the paucity of data on long-term follow-up of randomized trials over 15 years. Okay, if I could go to the next slide. So there are 4 major statin benefit groups. The first are patients with clinical atherosclerotic cardiovascular disease or clear secondary prevention. The second group is patients who have a primary elevation of LDL cholesterol of 190 or more and who may not yet have manifest atherosclerotic cardiovascular disease. The third group are diabetics aged between 40 and 75 years whose risk is because of their diabetes. Their LDL cholesterol is below the 190 threshold but above 70. And finally, and perhaps the most controversial group, are individuals who at age 40 to 75 years do not have atherosclerotic cardiovascular disease or diabetes, and their cholesterol level might be considered, LDL cholesterol might be considered normal. However, their 10-year atherosclerotic cardiovascular risk score is at or above 7.5%. And in fact, the data suggests that there is a continuum, and so there is a qualifier even for patients that are between 5 to 7.5 10-year atherosclerotic cardiovascular risk score might also be considered for treatment. If we could go to the next slide. So the treatment strategy is simplified, very simple. There are really 2 treatment groups, high intensity or moderate intensity statin therapy. The statin intensity is defined as high intensity, meaning a potent statin like rosuvastatin or Crestor, 20 to 40 milligrams, or atorvastatin at a high dose, with the expectation of lowering LDL cholesterol by 50% or greater. Moderate intensity statin therapy would be all of the other statin drugs or low-dose atorvastatin with the expectation of lowering LDL cholesterol by 30 up to 49%. The LDL measures are important, but it's to monitor individual response to therapy and adherence. But it's not that one are using these that you're using these lab values to chase a target. It's rather that you're trying to assess whether you're receiving the expected reduction in LDL cholesterol expected, and it is a good way once the kind of reduction that is achieved is measured. It's a good way to measure adherence over time. If I could go to the next slide. So treatment by statin benefit group is also straightforward. Patients with secondary prevention should receive a high-intensity statin therapy. Patients whose risk is that they have primary elevation of LDL cholesterol of greater than 190 should also receive high-intensity statin therapy. Diabetics, age 40 to 75, with LDL cholesterol below 190, somewhat normal range, should have the benefit of moderate intensity statin therapy. So, and again, in this true primary prevention group, patients without diabetes or atherosclerotic heart disease with an LDL that's between 70 to 189 milligrams per deciliter, but who have a 10-year risk that is either equal or greater than 7.5%, could be started on either a moderate intensity or high intensity statin therapy. The other considerations that would help consideration of whether when to start and how to, and whether moderate intensity or high intensity statin therapy would be to consider the family history of premature atherosclerotic cardiovascular disease in the first degree relative, or the presence of high sensitivity C-reactive protein that is greater than 2 milligrams per liter, or the presence of calcification, as an example, on a coronary artery calcium scan. I also want to underscore that in this primary prevention group, this is a group in which the prospects of statin therapy and benefit risk only make sense after you have talked about healthy lifestyles. And so this is the group in which the consultation and discussion with the patient and provider is really critical, and that consideration of therapy should include the patients to talk about the benefits and the risks, and they should not be discussed without a clear understanding and commitment to lifestyle, healthy lifestyle. If you go to the next slide. So let's also talk about statin toxicity and those things that may predispose patients to statin toxicity. So patients that have serious comorbidities, including impaired renal or hepatic function, of course are at higher risk from statin therapy. A history of previous statin intolerance would be an indication to depart from the standard guidelines. Unexplained elevations of the liver, the transaminases greater than 3 times the upper limit of normal should be of concern, and it should assess to see whether this is related to statin treatment. Patient factors or drug factors that affect statin metabolism, and this is really important with patients that are on multiple drugs, patients that are over 75 years of age, and other issues such as a history of hemorrhagic stroke. Asian ancestry are also known to increase the risk for toxicity from statin. I can go to the next slide. If you could advance one more time, I'm going to talk a little bit about the adverse effects. So among 74,000 subjects in 35 randomized trials with statins, if you would advance again, the incidence of elevated hepatic transaminase is really quite small, fortunately small, and especially if you compare that with the incidence of elevated hepatic transaminase in the control arm. Also, elevations of hepatic transaminase is often dose-dependent, that is usually reversible. There's a larger 15% incidence of myalgias, but also note that the incidence of myalgias is actually similar, if not greater, in the control arm. And similarly, there's an incidence of myositis slightly increased over what's seen in the control arm. But an important complication of statin therapy that should be monitored for is the incidence of rhabdomyolysis. Again, this is very small. It's a rare occasion, but it is important to be recognized, not only to interrupt statin therapy, but also requires treatment to prevent the consequences of this acute chain, of this process that could lead to other complications. So if I could go to the next slide. So this is a challenging time for healthcare in the United States. Our 2013 guidelines represent a dramatic change in approach to treating atherosclerotic cardiovascular risk and treatment of cholesterol. The resulting guidelines are practical, they're patient-oriented, focusing on available evidence to protect the cardiovascular health of patients. This is good for the patient, It manages healthcare costs and disease and may reduce disease burden. Future guidelines using quality evidence may address more complex patients. Eliminating health disparities is doable and a moral imperative. Monitoring outcomes and safety by subgroups with quality improvement oversight is important to achieve best outcomes. Continued research to examine sex differences in pathophysiology and to address subpopulations with greater risk, disproportionate disease burden, and poor outcomes is also needed. Ongoing monitoring of healthcare system differences in treatment and outcomes of care is important and is best strategy for healthcare equity. If I could have the next slide. In summary, cardiovascular disease remains a major health and economic burden. Cardiovascular treatment has provided benefit to all Americans. Women and racial and ethnic minorities often are undertreated. Quality improvement programs narrow treatment gaps. The 2013 ACC, AHA cholesterol guidelines focused on atherosclerotic cardiovascular risk disease reduction. A risk reduction strategy will benefit heretofore undertreated patients. Next slide. Treatment disparities are reduced with quality improvement oversight. Reducing atherosclerotic cardiovascular risk is central to improving cardiovascular health and reducing cardiovascular disease-related healthcare costs. Our new guidelines simplify therapy and focus on reduction of atherosclerotic cardiovascular disease events. Risk reduction will benefit heretofore undertreated groups. New guidelines and quality improvement programs promise to promote improved cardiovascular outcomes for all Americans. If I could have the next slide, I think that's it. All right. Thank you very much, and if there are questions, I hope I can answer.
Thank you so much, Dr. Devine-Nickens. Great presentation, and we do have a few questions that have already come in. For those of you on the line, if you have questions, please email them to hhqi@wbmi.org, and we'll get to as many as time will allow for today. This first question that we've received may have come in just before you finished your presentation, but it's a great point and one we might want to reemphasize. This question asks, with the new 10-year AHA-ACC cardiovascular risk calculator, can we still use the calculator for patients with Asian, European, or other descent?
Yes, thanks. This is a great question and one that has been talked about by our experts, and that is the new calculator uses actually National Heart, Lung, and Blood cohorts that include Hispanics, African Americans, and women. But the calculators, we should really be thinking about, we use these to calculate individual risk. And so some critics say, listen, this new calculator overestimates the risk for white women, and they're probably correct. So I think it's important for you really to consider the patients at hand and what methods you use to calculate their 10-year risk. But I think the important issue here is that the evidence that statin therapy, high intensity or moderate intensity depending on the risk of the patient, is relatively safe and very effective in reducing atherosclerotic events. So what we're trying to do is to prevent events. And so making sure that you're using a reasonable calculation of risk for the individual patient is really the important factor. And that is why not only is there this risk calculator, but you are also encouraged to consider the whole picture, family history, some of the things that are not a part of, for example, the newly recommended atherosclerotic vascular disease risk calculator. Thank you for that important question.
Our next question asks, Once put on a statin, does this mean you should be on it for the rest of your life? When should you come off of a statin or other cholesterol-reducing medication? 80, 90, end of life, ESRD, liver failure?
Sure. So, of course, if there is a complication for whatever reason, that's something that needs to be considered. But so first and foremost is that patients should be following a healthy lifestyle. Statin, so again, the cholesterol level itself, so as an example, if you're diabetic, you're not treating the LDL cholesterol, you're treating your risk and age group and other things that are going on. So for the elderly that are well controlled and are receiving secondary prevention, there's pretty good evidence that it's to their advantage to stay on therapy where they are stable. That is the highest risk. Patients with multiple comorbidities that put them at risk for atherosclerosis and have demonstrated benefit by statin therapy should probably stay on that therapy. However, evidence for how to or when to initiate in the elder population, I think there's less evidence, and we'll be looking to additional guidelines to do this. But again, I want to emphasize that our goal is not some target LDL, but rather to try to minimize risk for future events for patients. So if you're stable and you're tolerating your medications well and you're doing well, these guidelines could not argue to change anything. If, on the other hand, there is reason to be concerned about the medical regimen causing other problems or is not well tolerated, then backing off statin therapy, et cetera, is something that's considered. And sometimes patients who, for example, might be on intensive therapy, if it's not well tolerated, moderate intensive therapy is acceptable and probably conveys good risk reduction.
Our next question says, I've seen a couple of patients when a statin was ordered 3 times a week or every other day instead of daily. Is this a new recommendation? What are your thoughts on this?
Well, that's I'm afraid maybe that's something we should take offline. I am, the recommendations for statin therapy are, daily dose, maybe twice a day, but every other day. I'm not sure whether, again, maybe this would be better taken offline. It may be other conditions that are of concern. But again, I think we talked a little bit about those conditions that may exacerbate statin toxicity. While the guidelines make clear that statin therapy offer the best opportunity for risk-benefit to reduce cardiovascular risk, we must acknowledge that there are patients that are statin intolerant. And again, that kind of departure from recommended guidelines is probably an individual case and shouldn't be used as an example of how to treat patients in general.
And we have a related question, which, as you said, may be better offline, but it asks, for whom is light statin therapy recommended? Any examples?
Yeah, so the recommendations, again, they're very simple. If you have elevated risk as defined by these guidelines, secondary prevention, primary elevation of LDL, a diabetic with moderate LDL below 190, or patients that are otherwise normal and have elevated atherosclerotic risk over the next 10 years, 7.5% or 5 to 7.5% sort of intermediate, the recommendation is for high dose or moderate dose intensive, or not dose, high intensity or moderate intensity statin therapy. So light therapy is not part of the recommendation. I'm not sure what that means.
This next question says, many patients will forego this medication when they are on multiple meds to reduce their costs. Are even the lowest cost statins protective in nature?
So this is a great question, this is a great time for this kind of guideline. Statins were introduced in 1987, and at this time, many of the drugs, a high-intensity statin, or as you know, you can increase the dose to receive high intensity with something like atorvastatin. These drugs are becoming generic and will be widely available at very reasonable cost. So we're very hopeful, and with the affordable care, increasing access to care, that affordability of appropriate therapy to protect your cardiovascular health should not be an issue.
The next question asks, is there a relationship between the use of statins and the increase in Alzheimer's?
So there was a very careful review by the FDA that was published, I believe, in 2012 that talks about controversies in statin therapy. And there were several issues looked at, cognitive decline, diabetes, and there was another issue that was looked at. But as it turns out, statin therapy has been quite safe. There was absolutely no association with cognitive decline. On the other hand, the one thing that was suggested by this very careful analysis was that there are patients in whom the incidence of type 2 diabetes may be, may be exacerbated or may become more likely because of statin therapy. But the question asked about Alzheimer's or cognitive decline, that was carefully reviewed, and there was little evidence for that.
And the final question we have in the queue, it says, in either your research or through your practice, are there specific treatment strategies that work better for the African American population, both men and women?
So I don't have a particular approach to answer this question, but I think one of the really exciting opportunities in this approach is to recognize individual risks. And as I outlined in the talk today, African American men and women have high risk. They have higher prevalence of hypertension. And if we went through all of the risk factors, they tend to have multiple risk factors, including elevations of cholesterol, but not always. And so this risk assessment strategy may be very helpful and make the need to, underscore the need to treat these high-risk groups. So hopefully having this discussion with the patient, African Americans, or making sure that they understand their increased risk because of hypertension, as an example, or diabetes, or diet, unhealthy lifestyle, obesity, that those approaches will really strengthen the partnership between the patient and the provider to agree together of the importance of safe, effective risk reduction. And I think that is the dialogue that's needed. And again, the statin therapies are, the benefits have been so well demonstrated for all populations. Their safety is really quite remarkable, and they are relatively inexpensive. There are generics available that are very excellent. So this is an area to treat, making sure that African Americans receive the best possible therapy is a real opportunity that I hope our providers and practitioners and patients will try to take advantage of.
Thank you so much, Dr. Nickens, for both the presentation and the excellent Q&A session. At this time, I'm pleased to turn over today's presentation to Ms. Kevich, who is a Home Health Quality Improvement National Campaign project coordinator and the leader of our Underserved Populations Learning and Action Network. Ms. Dukevich will be talking about some of the HHQI resources that are free, adaptable, and available to everyone to support today's presentation topic. Misty?
Thank you very much, Shannon, and thank you, Dr. Nitin, very much. The information was excellent and I think applicable not only to our audience of patients that we serve, but even for ourselves as patients and with our own health. We do have a variety of home health quality improvement resources. As Shannon said, they're very adaptable to any setting because we do see a variety of settings that are on the call today with us too, not just home health agencies. The Cardiovascular Health Part 1 Best Practice Intervention Package, or BPIP as we call them, was released, believe it or not, in August 1st. And it focused on the first, the A and the B, which is the aspirin is appropriate and blood pressure control. The material is still available. There's additional resources that are available on the Home Health Campaign website under Education. We are going to have an update next month that will be related to the newer guidelines, and that will include the ACC, AHA, CDC guidelines, as well as the JNC8 and even the Diabetes Association updates that are related to blood pressure. So do look for that next month. Next slide, please. Cardiovascular Health Part 2, which covers the C and the S, is cholesterol management, which really did focus on the components that Dr. Nitin talked about with the new guideline changes. It included information prior to the guideline changes, and then we also had smoking cessation. We did provide in February a Cardiovascular Health Part 2 update. And to turn to the next slide, this does not replace the best practice package. It just complements it with the newest guidelines. The information is still very relevant. For example, the change from using the LDL as a goal in treatment, it was focused in the first package. It's still very viable in good information, but this update will provide you all the newest guidelines in a succinct manner. And it does focus on the 4 areas: treatment of blood cholesterol, assessment of the cardiovascular risk, lifestyle management to reducing cardiovascular risk, and management of overweight and obese adults. Next slide. For the home health agencies that do collect and submit OASIS data, there is a Home Health Quality Improvement Cardiovascular Risk Report. This is available for all agencies that do CMS reporting. And it is below your ACH, your medications, and your influenza and pneumonia reports that are available each and every month, looking at the OASIS assessment items that put your population at risk. So really just giving you a ballpark picture on looking at the population that you're serving and some of the key risk factors that we're able to collect through the OASIS data set. So they are there. If you're not sure how to interpret those results, would like to talk with someone, just contact us at our mailbox, which is hhqi@wvmi.org. We would be very happy to talk with you about that. Next slide. We also have the HHQI Cardiovascular Data Registry. We do have home care agencies that are submitting data, and we're actually this is a pilot project that we have done in this phase of the campaign. The focus of this data registry was on aspirin or other antithrombotics for those ischemic vascular diseases, and also looking at prevention, screening, and controlling hypertension. Those reports are for only those agencies that are abstracting the additional couple pieces of data to go along with their OASIS data collection. There are resources that are on the website, and that's listed in your slides. But again, if you are collecting and are receiving these reports or haven't downloaded your reports and like to have somebody to talk with you about your reports, talk about strategies, interventions, we'd be very happy, again, to talk with you. Just give us a contact through our mailbox. And the next slide. I do want to give you kind of a related upcoming best practice intervention package. Next month in April, we'll be releasing the second disease management focused best practice package, and this will be related to heart failure. Diabetes was released in February, and they all really do go hand in hand with the cardiovascular risk. So do look forward to the heart failure package that will be being released. Next slide, please. I do want to give you not the same topic, but before we open for any additional questions, the Gravity of Falls, Evidence-Based Preventative Strategies is an upcoming webinar April the 29th from 2 to 3 Eastern Time. Falls are a huge issue still within our populations for home health. We're going to have 4 excellent presentations or speakers on the call. We're going to be looking at multifactorial fall risk assessments and just talking about validating the risk assessments that you're using, how to identify and modify your thresholds to identify those that really are in need of intervention. We're going to look at prevention strategies for all clinicians, not just therapists and not just nurses. We will have a pharmacist on the call as well to discuss major classifications of medicines that increase the risk, as well as reviewing metabolic changes related to medications and age. So when we finish this conference today, you will be directed as you finish to end up on the page that you can register for the falls. You're actually our first audience that will get special privileges to go ahead and register, because we haven't even announced this fall's webinar yet. So I think that might go one more slide. I think that is our thank you slide. And Shannon, I'll send it back to you for any questions that we might have.
Thanks so much, Misty. Actually, we're about out of time for today, so we're going to go ahead and wrap up today's session. If we didn't have time to get to your question today, we will follow up with you shortly after the session. If you're viewing this as an archived recording online, you can submit your questions at any point to hhqi@wvmi.org, and we'll get back to them as soon as possible. And for those of you watching live, if you'd like to watch a replay of this, we will have the session archived and available online here in a couple days. Just go to www.homehealthquality.org to the webinars tab, and you'll see a recording of today's session. As Misty indicated, just a reminder, you will be automatically redirected to register for our next free webinar presentation, The Gravity of Falls, Evidence-Based Preventive Strategies, which will take place on April 29th from 2 to 3 p.m. Eastern. Thank you all so much for joining us today, and a big thank you to our keynote presenter, Dr. Patrice Devine-Mickens, and to Misty Kevich of the HHQI National Campaign for delivering this important life-saving information. Thanks for joining us, and we hope you have an excellent afternoon. Goodbye.